Hey folks, AshLThingsDentistry.com. So we're continuing the series with Dr. Partridge, our experienced mentor who's given us a lot of guidance in exodontia. So without further ado, Dr. Partridge.
Thank you, Dr. Mark. And I'd like to remind you again that this is kind of a two-way street here, so we really appreciate your comments. That's the only way you can improve the program and address the things that you're concerned about is if we get comments back. We discussed some preliminaries. We're just about ready to clean up on the preliminaries during this one. One of the things you have to do is your hard tissue considerations during your plan of attack. You want to look at the tooth anatomy, see how many roots there are, how it's spread out, and keep in mind that the radiographs are two-dimensional, but all your teeth are three-dimensional, so be prepared for the unexpected there. The location, the angle makes a big difference. I like to use the Pell Gregory classification, but they can be straight up and down, buried below the CEJ or behind the ramus and things. And the Pell Gregory is a good classification. Just it's nice when you're talking with your colleagues. It gives you a basic idea where the tooth is located. And then Boney access and reduction. Look at the area around there, see if they have any exostosis, have any tori. Of course, you want to look at anatomy structures around there, such as the inferior alveolar, the sinus, or salivary ducts, or anything else that's around there. So look at the hard tissue considerations before you do your plan. We'll hang up here. Okay, this is a Pell Gregory classification. It's an old classification system, but it's very fundamental. If it's fully erupted, it's A. If it's partially erupted, it's B. If it's buried below the CEJ of the next tooth, it's a C. 1, it's in front of the ramus. 2, it's bisected by the ramus. 3, it's behind the ramus. So if you got a 3C, that's probably an oral surgeon referral. And why are you taking out a 3C anyway, unless it's symptomatic? So it's just a quick down and dirty way of classifying the tooth. Okay, here's something that's kind of important when you're doing your design. In your mind's eye, or maybe some textbooks, you have a picture of a molar, and it looks nice, symmetrical, and all that, but it's not. And if you look at the one on the right, the real world, you'll see that most crowns are tilted about 15 degrees to your root, and they're not in line. The axis of the root is about 15 degrees off the axis of the crown, and that has two major consequences. Number one, if you dissect right down to the axis of the tooth, you're going to cut off the mesial root. The other consequence is that the path of extraction is not straight out of the socket, so it's going to be curved, dictated by the roots on the tooth, kind of like a curved path of insertion on a partial denture. The other thing I want you to note right here is a little dotted line there, and you see there's a significant concavity behind the second molar. And frequently when you have Mesio-Angular or horizontal impactions, you know where the crown's going to be. It's going to be right down in here. And so people are a little, especially when they start out, are a little timid about getting down in there, but that's where the crown is, and that's where you have to go to section that tooth out. Now this is an artist's rendition. It's highly exaggerated, of course, but this is what I'm talking about here. There's a big gap in the concavity right underneath the second molar there. So you want to do your buccal trough here. And one of the keys to extracting a tooth, you've got to get pressure on this mesiobuccal line angle to extract a tooth. So you want to get down there as deep as you can. You want to get toward the apex, not toward the crown. And a little distal trough, because this tooth isn't going to go straight out, it's going to make a curve here, so you have to have a little room there. Just stay one burr width behind you. Don't go too far back there. Your lingual nerve and other anatomical features are out there. The other thing I want to point out is preserve. Never take off the bone on the distal, that second molar, if you can possibly preserve it. As I always say, bone will grow horizontally across here, but it won't go vertically up. If bone would go vertically up like this, we probably wouldn't need periodontists. So make sure you always try to preserve that little bone on the distal of the second molar. Stay away from that.
Just before we go on, sir, I know that as general dentists in our office, we typically have impact air, the angled piece. I know here we're using straight pieces. Now, any thoughts on, before we start talking about more specific access, what are your thoughts on either use and the burrs you've been using?
A little bit of it's personal thing. I actually use both hand pieces, but for third molars, I typically like the striker or the osteomed surgical burrs. They have a lot more torque. They're a little longer, usually can get down into deep areas and that. But when I'm doing surgical extractions like endomolars or bicuspids or things like that, I like the impact air. It has a lot less what we call collateral damage. You can preserve a lot more bone, and you can do a lot better job of trisecting a molar to extract it than you can with the osteomed or the striker. So
you're using, by striker you mean the straight?
Striker and osteomeds are brands of surgical hand pieces. They're big straight hand pieces. Both of them are electrical motors. I usually use a 702. Sometimes I use a 703, but if you're starting out, I'd stay with a 702. The 703 takes off a lot of material, and you have to be really cautious and judicious when you use that. There's some, again, engineering reasons why I like the 703. Since it's got a bigger diameter, it cuts better. It's got more flutes, so it stays sharper longer in an area. It's a lot as far as a technical mechanical thing. But if you're trying to preserve bone and careful, you want to use a 702. 703 dissects teeth. You're not worried about preserving the teeth. You're going to section them anyway. So 703 is a lot quicker there. So you can argue that either way. But if you're starting out, I would stick with a 702 to minimize the collateral damage, reduction of osteo material there. And this is what I'm talking about, troughing an impacted tooth. This is just another ideal thing. Basically what you're doing is you're just not going in there and just taking out a lot of bone. You're following the contours of the tooth in the root. So basically you're doing a crown prep on the tooth and the root. You want to minimize the amount of bone that you take off there. So just in your mind's eye, whenever you're taking off bone, just think you're just doing a crown prep on the tooth and the root to stay close as you can to those structures and minimize the amount of bone you take off. Okay, flap considerations. After you design your hard tissue, then how you're going to take off, section the tooth, how much bone you're going to take off. Consider the tooth, the tori, and all those other things. Consider the degree of impaction. Then you do your soft tissue design. And one of the things you have to think about soft tissue is make sure that the base of the flap is always wider than the apex. And that sounds pretty simple on a flat sheet of paper that's two-dimensional, but remember all flaps are three-dimensional. They go around the hamular notch, over the retromolar pad, around something in a tori. So design your flaps real carefully, make sure they have plenty of circulation. Carpenters always use the expression, measure twice and then cut the board once. Well, maybe we ought to do that. Just design your flap twice and then make one incision so that you don't isolate a piece of tissue that'll slough off later. This is a flap design that I use. I've only seen a few other oral surgeons use it. It's for access in the posterior areas. A couple key points here. A lot of people use an envelope flap. They'll go all the way up to the first molar, maybe even the second bicuspid. Envelope flaps are good. The only thing I don't like about envelope flaps is every time you lay a flap, you lose there's a risk you'll lose a half or maybe a full millimeter of attachment. So I like to preserve the periodontium as much as possible. So what I do is I start in between the contour and the papilla. I like to preserve papilla because they're important in the anteriors for aesthetics, but in the posterior they're important for preventing accumulation of food and periodontal disease down the pike. So I keep the papilla intact, cut just distal that, and if you'll see this cut that I'm doing here, the base, it comes out at a 45-degree angle toward the anterior. See it over here too. And you'll see that little beveled line, that little dotted line. The blade is not held perfectly perpendicular to the bone, to the mandible or the maxilla. I tilt the blade slightly distally so that the blade is going distally, but your handle is going anteriorly toward the mouth. So this is kind of undercut this flap here. And the reason is you have a beveled flap. So when it comes time to close that, if you can't make a perfect butt joint in your flap, you still have a beveled flap, so that can slide 1 or 2 millimeters either way, and you'll still get primary coverage on that area. As I extend the flap around, I just stay in the sulcus and go all the way to either the distal lingual or the distal palatal edge. And then I come out of a semicircular cut like this out toward the buccal. Now, it goes through the mesio-lingual cusp, right over the central faucet and over the distal buccal cusp like that. There's 2 no-cut zones here on the lingual side because the lingual nerve, and also here you have the greater and lesser palatine foramens and their arteries and nerves coming forward. So you want to stay away from these areas. If you do have to remove this area to deliver the tooth, you can simply just reflect it real gently. Don't stretch it out because, again, the lingual nerve may be in there. 5% of the cadaver studies show that the lingual nerve comes almost immediately distal to the third molar and right along almost the lingual surface of the third molar. So you want to stay away from the lingual nerve. It's bad enough cutting an inferior alveolar nerve, but the lingual nerve has a lot of proprioception. So if you numb that up, every time they talk, laugh, sneeze, cough, they'll remember you. So you want to preserve that lingual nerve at all costs there. Now here's a couple of anatomy drawings here, and you can see this is a standard one where it's pretty close right there. Both of these you can see how the lingual nerve is really close to the third molar. But again, about 5% of a cadaver study show that it even goes closer, almost immediately distal to the third molar. So stay away from that lingual nerve. You'll save yourself and your patient a lot of misery. Okay, there's a lot of, we've gone through a lot of pre-ops and preparatory things here in order to start surgery, and they're very important that you do all those things, but you don't have to spend 45 minutes or an hour going through all those things. Once you get proficient, you should be able to go through the, make sure your medical stuff's ready, but through the medical history, do your assessment, do your planning, make sure you have all the instruments there and plan your attack. And you ought to be able to do that in 15 or 10 minutes without any problem once you get proficient. But it is important you go through all those steps. If you skip a step somewhere during that preparatory phase, you may end up paying for it a little later on. So again, once you get proficient to these things, it'll go pretty quickly. It seems like pretty lengthy when we go through this discussion, but once you get good at it, you can slide right through those things. But it is important you do each step. Okay, now we want to get into some of the actual surgical cases off of radiographs. This is a mesial angle, which is one of your most common impactions that you'll see. So this is a good place to start. Now, in my mind's eye, of course, being the old engineer, I like to diagram stuff out real well. So I'll look at that radiograph at that mesial angle, and I'll just kind of survey it real quickly. And you notice the outline of the tooth is kind of cone shaped. So if it were straight up and down, you could probably extract it right out of there. Unfortunately, the diameter of the roots is smaller than the diameter of the CEJ, so it should extract, except it's lodged right underneath that concavity in the second molar there. So you look at the axis of the tooth, and you see that the axis of the root is, again, about 15 degrees difference from the root axis of the crown. So if you come right down through the crown axis, what are you going to do? You're going to cut right into that mesial root there. Also, I'd like to point out, I think you can see it better on the next radiograph. Oh, notice also it's going to be a curved path of extraction. You can't take it straight out. Just as a side note here, remember what I told you earlier, there's usually a 15-degree divergence. See how the crowns are pretty straight and vertical there, horizontal occlusal surface? Look at the roots. They're both about a 15-degree angle, so that's just standard anatomy. So I'll dissect the roots. I'm not worried about dissecting the crown. I'm worried about dissecting the roots right down the middle. And you can see, if you go right down through the middle of the roots, it's going to come out on the mesial cusp arm or the mesial cusp, not through the furca there. Now, another thing when I make a groove, another tip, I'd like to make the groove at least halfway to, or at least 3/4 or maybe 7/8 of the way through the tooth. If you only make it halfway through the tooth and you crack it, you don't know where that crack's going to go. It may not split the way you want to, and then you made a mess out. Then you have to retrieve it. The other thing I do, I like to make the outside of the groove section wider than the inside, and that allows me to seat the instrument down deep. If this instrument seats up here on the crown and you twist it, all you're going to do is chip off some enamel, break off the crown. You want the binding point of your elevator or whatever you're using it to be down in the center of the pulp floor, right in there, so you can split the roots. So you want to make the outside of the groove wider than the inside, so you can sit that instrument all the way down to the bottom of the pulp floor, and then you twist it, and you want it to bind down there. Then you can section the roots that way.
Just for the answer, some of the things I've seen a few oral surgeons do. You do this after you would trough first, and then start the sectioning from furcation. Usually, when you're doing the section.
If I can find a furca, I'll start at the furca and come up. But a lot of times you can't see the furca. It's kind of a blind sectioning, and so that's why I like to uncover the crown. One of the things I use a little 15 scale. I scrape off all the periodontal ligament around it, get a good view of the crown, so I know where the buccal groove's going, and then I can estimate where the furca is, and then I start on about the mesial cusp and then angle down toward that. And so sometimes you have to do it blind because the furca is so far down in there, you have to remove a tremendous amount of bone to actually see it, visualize it. Other times I'll actually get down there with a scaler and slip it down there. A little 15 scaler, it's a real small little scaler. I use that a lot. I use it almost like my 6th finger. You can slide it down in the PDL there and you kind of feel where the furca is. So that's another little tip you can. Okay, here's another artist rendition. As you can see, that sectioning groove is in front of the buccal groove. If you go right down through the buccal groove, you're going to be in problems. And again, it's a slight angle to the crown. And this is a sequence. Once you section that, obviously the mesial one is locked underneath the second molar in that concavity there. So you take out the first one, and it's going to come out at a slight curve like that. And then what I do is I get a purchase on this little mesial buccal line angle and just tilt it distally a little bit, and then it'll come out of there. Okay, now that's the way you're going to section the tooth. Now how do we prepare the bone for that? Well, you have to do a little bit of a buccal groove around here. And again, just a single burr pass on the distal that gives you a little room for that tooth to go distally. Again, this yellow line here, you want to preserve that, especially at the back, at the distal of the second molar. The mesial buccal root, like I say, it's key. You got to get your elevator down as far down on the mesial buccal line and get leverage to elevate it out. If your cinch point is up here, all you're going to do is just break off a piece of the crown. I might add an admin note. This is my 3rd edition, and when I changed it, it gave a different background color, and sometimes it'll refer to a yellow line that's orange, and sometimes it'll refer to an orange line that's purple, and some areas I had that were black are now red, and I'm not sure how Microsoft add pigments to black and make it turn out red, but somehow they did it. So the colors in the narrative may not exactly match the radiographs, but hopefully you can figure it out from the text. Okay, now we know how the bony access is done. How do we get a flap to get the bony access? This is a case where I use the anterior releasing incision. The tip of the crown is almost a Pell Gregory 3, so anytime it's a Pell Gregory 3, I tend to use this access rather than taking an envelope flap all the way up to the bicuspid. Again, you'll see the base of the flap is wider than the apex. It's undercut here, so this little bevel area right in there. It doesn't have to be perfectly butt joint. You can kind of slide around to make a good juncture and primary coverage. Take your incision all the way around the distal lingual, and you come across here, but central fossa distal lingual, and you come out almost at a 90-degree angle. Now, if you survey this dotted line is your axis angle. So when you pull the flap back, all this will be exposed from here up to your yellow line. And there's quite an area there. You should have plenty of area to operate surgically there. Also note that the dotted line, the hinge axis, is much wider than the apex, so you should have good circulation in that flap. It should survive without any problems there. Okay, we'll go to another common one, the distal angular, which we see quite frequently. Again, in my mind's eye, I'll just do a quick survey on this guy. And again, you'll see it's cone shaped. So the roots are narrower than the CEJ. So the old traditional ice cream cone, it should pop right out of there once you get some good elevation on it. The root angle, again, is a little bit of an axis, a little bit of an angle to the crown axis. Just consider that. The problem we're going to encounter here when this comes out curved, what are you running into? You're running into the little lip of the ramus there. So that's going to bind right there. It's not going to elevate as long as you got the distal crown pounding against the ramus there. So what are we going to do there? What I do is I'll just take a little distal section out of that crown. I'll start about the mesial cusp angle. I'll come down here toward the distal marginal ridge. I like this cut to extend down to below the CEJ or right at the CEJ. And then a little distal groove right here. And just take this part completely out of there. And as you see, you have a pretty good space there. That used to be black. Somehow Microsoft turned it red. I know. I have to go back and study my pigments. I don't know how you had pigment to black and turn it red, but they managed to do that. One other side light I might answer here. Let's see, it may see it better on the next. That's the way. Once you take that out, then the tooth should extract right out through that open spot there. Did I miss the Boney? Oh, there's a Boney reduction there, sorry. A Boney reduction again, you just do a simple buccal trough here and a little bit of the distal there. And that should give you plenty of room to access the tooth so you can section the tooth properly. And your flap, again. You don't need an anterior releasing incision on this. Is a Pell Gregory B, so you don't need that anterior releasing incision. Just go around the buccal, the distal there, and make your distal releasing incision. There's your hinge axis, plenty of access in there. Should not have any problem getting access with that flap. You have good circulation. I'd like to point out a couple other things on radiographs real quickly. You'll see see that little bony interceptal bone in there? You'll notice it's kind of an island. It's cut off, but the root tips touch each other. When you see a bony island of interceptal bone, that's almost inconsequential. It's probably not attached to anything. It's really not a consideration as long as your roots are narrower down here than they are at the top. Compare that to the adjacent tooth where you have a long, skinny peninsula of bone, interceptal bone that's connected to the mandible there. That may be a problem. And when you have long roots like this, if it doesn't come out real quickly, I'd go ahead and section the tooth, because if it breaks, it's not going to break up here. It's going to break about halfway down the root socket, somewhere in that peninsula. So big difference between an island of interceptal bone and a well-connected peninsula. So that's something to consider when you're taking those out. Okay, I think that's about the end of our time for today. Hopefully you can assimilate all that. And again, we appreciate your comments and feedback on that. That's the only way we can improve the program. And so without further ado, Dr. Mark.
All right, thanks for your time, sir. And we'll be back with more.